Well, good afternoon, everybody, and welcome to today's Health and Wellbeing Board. I'd like to start today's agenda with apologies for non-attendance. So over to you, Lisa.
Okay, we have apologies from Cornelia Andricott, Michael Jones, who is hopefully represented by Martin Claydon, who I don't think's made it here yet, Jonathan Cox, Pratima Dattani, Jacqueline Parks of the University of Northamptonshire, Colin Smith from the local medical committee, Anne-Marie King from community pharmacy, and Carl Wilson, who's deputised kindly by Paul Cash.
Thank you very much. We're pleased to know that's the first item on the agenda out of the way, so we're doing well. Next, I understand that there's no notifications for requests to speak at the meeting today. And we'll move on to agenda item 3, which is declarations of interest. So I invite members here today to declare if they've got any disposable pecuniary interests or non-statutory disclosable interests on the items of today's agenda. If a board member declares such an interest, they must remove him or herself from the whole of the item. When declaring that interest, board members are asked to state the item in which the number they have an interest, the nature of that interest, and whether the interest is a disclosable pecuniary interest or non-statutory interest. And as is normal tradition now, I shall declare my own interest, which is I'm a partner governor for Northamptonshire Healthcare Foundation Trust. So are there any other interests that need to be declared? Looking around the room and seeing none. Okay, thank you very much. So we'll move on to the minutes from the previous meeting. So I invite the board to approve the minutes from the previous meeting held on the 30th of September 2025. Are there any points or of accuracy or any comments that members around the table want to address as part of the minutes? Are you all happy if I sign them as a true and accurate record? Could I have a show of hands in favour, please? Any against? And any abstentions? Thank you. We'll record that and I'll be happy to sign the meeting minutes. No, you're more than welcome, Sarah. Okay, we're actually on item 5 on the agenda now, which is the action log. We have 2 actions on the action log. Both are in progress, so not really for the board to sign off as yet. The second one of the action log, which is around coordination and integration of all relevant strands of work to support the collaborative efforts on smoking and vaping. Hello, good afternoon, Prince. I know it's been a bit of a journey for some, and I think the car park has been a bit of an issue, so we may have people coming in a little bit late, but thank you for attending. We're on item 5, Prince, just so that you know. And I was just making a point about the second action log, which is just a plea as chair that if you as board members do wish to get involved, please either speak to myself or Lisa, and we can add you in, and we can start to track some of the progress of that collaborative work around smoking and vaping. Okay. So moving on to the next item of the agenda, which is the Chair's introduction. So Once again, just to welcome everybody, and to those people watching us on the YouTube channel, it's good to see those of you who are attending for the first time. I'd also like to welcome Councillor Lee Duffy and Eileen Doyle from the Integrated Care Board for Leicester, Leicestershire, Rutland and Northamptonshire to the board. So a very warm welcome to you both. Before the meeting gets underway, I would just like to thank Judy Matthews for kindly stepping in at very short notice to present the annual report from the Northamptonshire Safeguarding Children's Partnership. Judy, it's greatly appreciated. So you're up twice today, but thank you for stepping in at short notice. And just a quick reminder from me around mobile phones. If you do have a mobile phone, could you please make sure that it's either switched off or turned to silent for the duration of the meeting. I am aware that some people may need to leave during the meeting, so those have already notified me. There are no fire alarms planned during the meeting, so if the alarm sounds, please leave via the doors at either end of the chamber and vacate the building using the stairs. We encourage all board members to contribute to discussions today, but please do raise your hand and wait to be recognised by myself as the chair before speaking. That will ensure that everyone is clearly heard, and it also helps our minute taker. I'd like to take this opportunity to let everybody know that the next meeting in March, we will hear from those who took part in the national level of pandemic preparation exercise, which affectionately is known as Operation Pegasus. I've had a briefing on that, and it's quite some task and exercise that's been undertaken. We'll hear details of the strengths and learning that we can take away from this really important piece of work. So that's my chair's introduction. On to the next item of business, which is a very welcome one from my perspective. Our order of business is a pleasant one in electing a vice chair. So I'm delighted to nominate Eileen Doyle, the Chief Delivery Officer for Leicester, Leicestershire, Rutland and Northamptonshire Integrated Care Board. I believe Councillor Eddie MacDonald is happy to second.
That's correct, Chair. I'm happy to second that nomination.
Thank you very much. And for the board has to vote on this, so I'm very... Eileen's already been pre-prepped, so she has to leave, just in case we need to have any discussions about this. But if I could ask the board if they are in favour, if you'd like to raise your hand of Eileen becoming the vice chair of this board. Are there any persons on the board who wish to vote against? I'm seeing none, and I think by process of calculation there should be no abstentions. So thank you very much. Lisa, could you ask Eileen to come in? Eileen, I'm delighted to tell you that it's been absolutely unanimous, so I very much look forward to working with you as Vice Chair of this board, and I think on that point a round of applause is in order. There you go, Eileen, you don't know what you let yourself in for. Okay, so moving swiftly on, we'll move on to the health and wellbeing strategy overview, which I think is going to be a programme update, Lee, from you on a verbal basis. So over to you. Thank you.
Hi. There are no papers for this because I think some time ago we decided that we would do this once a year, but there was a slight mix-up with the agenda, so I have brought a verbal update. So I'm going to go through 4 of the priorities, and then the 5th one is the key focus of our presentation today, which myself and Andrew will be delivering on. So the first priority programme would be smoking and vaping. There's been completion of the commission of the NRT framework, and Stoptober campaign materials went ahead, which also included delivery of a legal tobacco campaign and vape campaign, Stop It, Spot It, I think it was called. And there was work around the youth and prevention work to establish a children and young people smoking and vaping work stream, and 2 meetings have been held with a review of data and the agreed focus areas. Secured stop to swap or swap to stop funding to expand the smoking cessation support within the substance use treatment system and inpatient NHFT. So I'm presuming that's at the hospitals. There's also been external workplace stop smoking offers approved for trial in some of the engaged workplaces, and a children and young people's work stream agreed with shared priorities on prevention, education and early intervention. And there's a final element of Operation Stop It, Spot It, successfully closing the project, and I presume there'll be an update at the next time this comes for key priority area. Financial resilience is a second key area that's outlined in the strategy. There's currently commissioned funded programmes supporting financial resilience. These are continuing but not fully mapped as yet. Theory of change specification tendered and awarded to accommodation concern, and new VCSE grants under HSF7 launched, including elements for budget management support, and the annual Year 1 reporting relating to NNC VCSE strategic grants is in draft form, soon to be published. The achievements outlined were around financial gains, and the example given was around SNN Q2 impact report showing full financial impact for service users of over 913,000. And the data return has been submitted, and adult learning service independent economic impact report shows £26.58 economic benefit return on investment for every £1 spent. Unfortunately, there's no context with that, so hopefully you don't have a question for me on that. Key area 3 would be healthy weight. Three work streams have taken place with 2 meetings in July and September. Body Happy Org has presentation, introduced their body image interventions for schools and gathered feedback for schools regarding the need for body image interventions. Healthy Early Years meetings set up with other local authorities to be able to work together, and a specification to commission training across the local system has been in train. With what took place in the last quarter was around summer holiday programme, and school-based place working has now commenced in the new term. Achievements: the commissioning of compassionate approach to training and professional advice is live and being built into the ICB weight management services review. Supervised toothbrushing government-funded programme training is completed, with 5 schools agreeing to sign up to the supervised toothbrushing programme. The National Child Measurement Programme changes have been made to encompass the wider health discussion with pupils before the measuring activity. And Active Families pilot for family stays at 2 primary schools, and another to be coming on in September, or another started in September. And there's been a confirmation of the HIAA funding for a street tag project in Corby of £25,000. And then children and young people. The initiated Theory of Change workshop has now gone ahead, and there's continuing development around systems leadership programme and work on the Environmental Justice Index with natural capital solutions, focusing on indicators such as green space and environmental risks. So it's about getting people out into those green spaces. The achievements and successes were listed as strengthening the cross-sector collaboration in primary care, leisure, public health and VCSE, with a series of meetings which took place over the last quarter, and the second place expansion test and learn project launches soon. And re-establishment of the Northamptonshire Sports Network and VCSE funding opportunities secured and additional prospects identified. So there's quite a lot of activity in the last quarter. I think some of it you'll probably have heard in the smoking and vaping update from the last meeting, because they did their focus area on that. Okay.
Can I open it up for questions? Okay, thank you, Lee. Thank you for that update. I'd just like to open it up for questions from the board for Lee on her update. Anybody got any questions that they want to ask? Prince.
Thank you, Chair. Just a couple of things I want to kind of raise with the report and the update, but I think it's very comprehensive. Recently, with the HSF 7, what I've heard from other organizations was the fact that there has been a drop in terms of their ability to cope with the demand. So there is a lot of demand, but then the capacity to deal with that is gone down. Christmas happened to be one of the off times when people would donate, so therefore it doesn't really reflect the reality on the ground in terms of what the VCS organizations are facing at the moment. The amount that was distributed recently wasn't enough as well, from what I've gathered with other organizations, and some would struggle after this month if nothing is done. So I guess the question is, how do we ensure that there is other continuous pathways or investment into our VCS organizations to make sure that they don't dip down and be at a stage where they can continue to support the vulnerable and the lonely people in the community?
Okay, sorry, thank you. Thanks, Prince, for that. So, Household Support Fund, is that what you said, HSF? Yeah. So, Household Support Fund, as people will be aware, has been running for a number of years now, and it does a really important job in supporting people who are really vulnerable in terms of a whole range of different things around school holidays and around all sorts of different things. The first thing I'll say about Household Support Fund is it's quite a difficult fund to administer. That we can only spend 5% on admin of that, and that in itself makes it really difficult to get the money out the door, frankly. It is a requirement of that grant, if that's all we can do. And I know that the team are always looking for cunning ways to get that out. The other thing is, obviously, the long-term picture for HSF and what that's going to look like going forward is always something we need to consider. I can't speak for the team aren't here who administer the Household Support Fund, but if you have a specific question, I can take that back to the team and come back. What I would say about broader VCSE working with our most vulnerable communities, we do have a number of different initiatives that are going on around that. Partly, obviously, we've got our Aspire NN contract, and we've got people who represent that here today, which is about building some of that infrastructure for the VCSE. But we also have small grants programmes as well, which are funded through a whole range of different ways, including public health, for example. There's some small grants programmes that are funded by public health. I think ultimately, it's only ever going to be the case that there will never probably be quite enough money to fund all of the needs that we see in our communities, but we have to be smart with the money we've got. I'll come back on that specific question about HSF and get the team to respond to that, Prince. But I think what we all need to be doing is thinking, how do we make the most of the money we do have? How do we make sure that the grants that go out are meeting need in the right way? I know that the grants, for example, Lee just mentioned one to the HIA funding that came through the NHS that we're getting towards the end of now, but those projects are being commissioned and they're starting. That is another way to diversify the offer around what we can do with our fantastic colleagues in the voluntary community, faith and social enterprise sector. When that money comes to an end, we'll have to think, well, what comes next? But I think we're always on that journey. And I'm looking over at Kate and yourself, Prince, and Sarah, and all those people that fully anticipate that and understand it. But yeah, it's going to be an ongoing piece of work for us.
Thank you, Prince, and thank you, Jane, for that comprehensive answer. I think we'll take it as an action, Lisa, to come back to you, Prince, if that's okay. From my own perspective, I think it is one of those questions that's a bit like the Forth Bridge. Just when you think you're getting there, you've got to start all over again because, you know, funding streams change and organisations change and things like that. But I think if we can build what we're trying to build here, which is working in partnership and working in collaboration, we'll get the best, what I call, bang for our buck. So, you know, I think we just need to continue to try and look, as Jane said, at every possible avenue to make sure that those support grants and support activities are spread as far and as deep as we can make it with the resources that we've got available. So, thank you. Are there any other questions? Kate?
It's just to add to what Jane said, really, and it's credit to the grants team at NNC, because we, through Aspire, we facilitated various conversations because there was the sort of call out that it wasn't enough to be able to deliver those grants. And the grant team did have some conversations with the sector, and they've looked at how they can deliver it, what flexibilities there are. So I think everybody is trying to make the most of what they can with that HSF funding. I think they're all published now, so the other thing to do is, if you aren't involved in them, is to find out who is lead for different ones and connect to them and connect the communities that you work with into them so people are benefiting from it.
Thank you, Kate. I can't see any other hands raised, so thank you, Lee. I've got, I'm not quite sure whether it's yourself or Andy Lee are going to do the update on mental health. So, Andy Lee, I think it's over to you.
Lee.
Oh, Lee, and then Andy Lee. I do apologise. Thank you.
So I've been asked today to give an update for the key area around health and wellbeing boards, mental health and suicide prevention strand. I think it's been quite a while since this came, so there is quite a lot to talk about. Can we move to the next slide? So I think the first thing to say would be that some of the stuff that I'm going to talk about today relates to suicide. Which can be quite an emotive topic. Just a pre-warning about that I am going to talk about that. I have to do that. It is a real priority for us, and I think it's worth saying right at the beginning that it is thankfully and mercifully a rare occurrence of suicide, but if anybody does need to step out or needs to chat afterwards, I'm happy to be around. So just a little bit of background. The Health and Wellbeing Board strategy 2024-29 was agreed in December of last year. There are 5 key priorities, each with an executive sponsor and a workplace lead or workstream lead, and public health officer support, which is Anthony, on this particular strand. Progress is tracked and monitored by the Health and Wellbeing Strategy Oversight Group, so each month we get together and check those action plans. But as part of this process, each of the key strands comes for a more in-depth presentation. Next slide, please. So just for information, that's the 5 key areas, and we're concentrating on mental health and wellbeing today. So next one. And the next one. So the programme approach, there are 3 specific objectives with this, and we're going to concentrate on all 3 of them today. I'm going to take the first one, which is refining and strengthening our current work to reduce self-harm and suicide prevention. And then Anjali is going to take over from me and talk about the second 2, the increased focus on reducing smoking in people with serious mental illness, and improvement of physical health, and some of the work we've been doing around that. And then some more in-depth work around mental health-related inequalities that we've been working on as a team. What we're not aiming to do today is talk about all mental health issues. We are concentrating on the 3 strands of this particular key area of focus, which relates to the Health and Wellbeing Board strategy. Next slide, please. So suicide prevention. Refine and strengthen our current work to reduce self-harm and suicide. So I'm not going to talk about everything related to this. I'm going to focus in on one piece of work that we've been doing over the last quarter. And it's part of our approach to reducing self-harm and suicide is a retrospective audit. It's conducted and then combined, the data is then combined with a data analyst, and it's analysed to identify commonalities. The analysis enables us to work with that information, and then those people who are working with our residents can develop the tools to understand potential risk factors. So it's a way of understanding what's happened, and it gives us an opportunity to pull out some specific strands from that data. So we're using real evidence of people who are living in Northamptonshire. So one of the things that we've also informed would be the development of a partnership suicide prevention strategy, which is in train at the moment. So we'd use the information alongside other information that we've got around Northamptonshire and from our VCSE colleagues and from our various mental health strands of work to develop that suicide prevention strategy. But this is one element which I'm going to talk about today. We also have a specific training, and what we want to do is inform that training so that we upskill our workforce so that they know the things that are coming to us in Northamptonshire. What we've also been able to do is, by analysing the deaths in this county, we can recommend specific actions to board, which actually enhances our ability to work with our residents to prevent suicide. So that's one of the reasons for doing it. Next slide, please. So the story so far is the data analysis is completed. What I mean by that is our data team within Northampton Council have taken that information from our coroner's reports, from our case records, from our partners, and have put that into a data-specific report. Now, what I'm not able to do is share that full report with you, because that gives us quite detailed information about people's lives and obviously has information about their families. So it would be really unwise for us to share that. It would be really unfair. Because also there's quite a lot of small numbers. As I said, it's mercifully rare that people take their own life. And what we don't want to do is tell you who those individual people are. That's really an unfair place to be. So because those numbers are small, quite a lot of that data's identifiable. So we've chosen not to share the full report. So what we're doing as a specialist public health team is looking at the analysis of that data and saying, what does this mean? So for instance, if it tells us about somebody's sexuality, then we don't want to share that because it may well only be one person and that identifies that individual. So what we're talking about is general findings from it. So we will at some point publish an audit report, but as I said, it will have redacted small statistical data for that reason. Next slide. So what I'm talking about today is the things that I can share with you and the things that are relevant for this group and the things that inform us in what we're doing around suicide prevention. So what we've got there is the initial findings. So it's done at you'll notice that some of the tables and graphs follow different years. That's because they're from different sources. So it's really difficult to find one specific set of data that we can compare. So we've used our best judgment on this. So table 1 tells us in numbers rather than percentages, and it comes from the Office of National Statistics. But it tells us about the number of people when we compare it across England and Wales, East Midlands and Northamptonshire. Then what we've done is then take that and over a 10-year period say, what does that mean for Northamptonshire? Our source for that is a fingertips. So it's a different place that data comes from. So it covers a different set of years. So whilst we can't compare the two, on data analysis, we can look at them in comparison. What you'll see there is some small lines, those black lines that go up and down, they're called confidence intervals. And what that tells us is that we are in line with the national average, what we're expected to be. What we want to see is that both the national average and the North Northamptonshire average is 0. Unfortunately, it's not. But what we can say is that we are neither above or below the national average. We're where we would expect to see that data. So we fall within the confidence intervals of the England average. Next slide. One of the things that came out from this data was that both nationally and locally, males of a particular age group are more likely to take their own life. We've looked at stats from 2013 to 2023 on NOMIS, again, another data set. So we're bringing all these data sets together. And what it tells us is that, on average, in North Northamptonshire, there are more males than females. That gives us an understanding that that's possibly a group we want to look at. A different source of data underneath then tells us the average age of those people. So what we're looking at is our focus being on a particular age group. So it's a startling, really, that we're looking at a particular age group of males within our region. Again, I haven't got the comparison with the national, but it is in line with the national averages. We almost already knew that that would be there. We would have been surprised if it wasn't. Not to say that we don't want to do anything about it. That's entirely the point of doing this exercise. Again, that was local data that came through our coroner's audit, presented by our data intelligence unit. Next slide, please. What's also of interest is we've compressed that into where those people live, but we haven't done it in ward area. What we've done it is by deprivation quintile. So that's basically the most deprived area being number 1, which is the left-hand graphs, and the least deprived area being in number 5. And you can see a spread of where people live in terms of those deprivation quintiles. It gives us an idea of the type of life that person's leading. We are slightly out of kilter with the national averages in that our percentages are higher in decile 2, but in real terms there's not that much difference in numbers between the two. So although it looks different on a graph, in actual numbers it's not that different. The other thing that came out was in figure 4, which was around marital status. I will say, first of all, these numbers don't add up. If you're trying to make them be 100%, they're not. We were trying to make it balanced. They're not our figures, and it would appear that some of it has been left out because there was it's just not there. So it's not been put in the not recorded box. So we have realised there is an error on that. But what came out of that was around people living on their own. And it fits with that national picture of isolation and loneliness being a key factor in people's mental health. Next slide, please. So what we come to is picking out those key audit recommendations. So we picked out 3 as a working group. A focus on prevention in the cohort of males between 45 to 64 years old. Anjali's going to talk about a little bit about what that means in the work that we're doing across the MHLDA and public health and other parts of the system. What we're doing is saying there's a highlight on this group. We're not saying that's the only group that we're going to work with. We've incorporated within this within the training offer potential trigger points. So that comes into our loneliness and isolation. They're interlinked, so they're not sitting separately. What we're saying is within our training offer, we want to make sure that that's included, that professionals attending that training understand that that is a factor, and it might be something they want to look out for, which potentially might prevent a further loss to life. And then finally, we've been looking at our combined healthy lifestyle service and developing as 2 strands of public health of working together. So bringing together those healthy lifestyle services and green space use, physical activity, moving more, and also putting into that how we can target particular groups of people around loneliness and isolation so that we can promote good mental health. Next slide. All right. I don't know if you want to do comments and questions first on that, or whether we want to move on to the next section.
Has anybody got any burning questions for Lee so far? Or Prince? Yeah. And then I'll come to you, Lee. Sorry.
Yeah, thank you, Chair. Just a couple of things whilst Lisa was talking. I know you didn't, you deducted what we've seen, which is great. But again, in terms of the 3 areas, and even before I touch on the 3 areas, how many do we know are from ethnic minority? I know the numbers are really small, and as you said, I mean, how small, I don't know. But, you know, do we have that information in terms of the numbers in terms of ethnicity? And also, the 45 to 64, I know you said that's not the only target group, but why was 45 to 64? Is there a particular reason for targeting that as the main before looking at the others? And I guess the third point would be, in looking at the 3 areas you've mentioned, it's also what assurance do we have of the workings within our VCSE partners in more practical way to, you know, proactively, you know, engaging and targeting some of these areas. Okay. Thank you.
I'll start first with the age group. This comes from the data. It's not randomly picked out. This is what the data is telling us. This is what the numbers are telling us. As I said at the beginning, we're not saying that we're going to ignore every other age group. We're saying that we want a particular focus on this age group because that is a particular risk factor. We know from the evidence and the research that is a risk factor. So that was why it's been picked out. It's not that that group is a special group. It's that that's what the evidence is telling us. In terms of ethnic minority, we do have that information. It is recorded on coroner's audits. What we haven't done in this, because it wasn't a particular group from a particular ethnic background that was presenting in the data, we haven't picked it out as a key recommendation. What we'll aim to do in the analysis report is give a more rounded approach to that, so we can say where we think that those instances were, but in terms of it picking it out as an audit recommendation for risk factor prevent suicide, it didn't flag up as a particular concern. But we do have that information. To share it in the format it's in at the moment would have meant that we had identifiable data. I don't know if somebody else wants to take that one. I can't actually remember. Could you repeat the VCSE question?
Yeah, basically, is what assurance do we have within our VCSE that there will be much more, you know, collaborative approach in more proactive intervention in some of these areas? Because I know that within our VCSE organizations, Chair, there are those who are trying to engage some of these families at a very early ages and in their critical situations. I personally had a gentleman who came to the office who said he nearly committed suicide. And so it's about how do we make sure that organizations that are addressing some of these things are partnered into some of these, you know, workings to help in that process. Yeah, thank you.
Thank you, Prince. So we have got locally some specific organisations in the VCSE that we work with around this particular topic. Lots of you will be aware of Kelly's Heroes, for example, and there's lots of other organisations that are doing some amazing work. I think the key issue for me is how do we make sure that anybody in a frontline position, so whether that be in the VCSE, whether that be our staff who are working in adult social care, our smoking cessation staff, because people often share experiences, stories, concerns that can be quite frightening for that member of frontline staff. I've had a number of people say to me, for example, I'm really worried sometimes that people say things that make me fearful that that person is suicidal. And that's a really difficult position to be in, and then going home and worrying yourself about that individual. So one of the strands of this work is to make sure we've got a really strong training offer to support people. And there's a couple of bits to that. One is around how do you identify people who might be at risk. But there's also a very specific skill set around working with people who are bereaved through suicide as well. Bereavement for anybody is extremely harrowing. Bereavement through suicide can be extremely difficult. And I know from talking to people who've been bereaved through suicide that there can also be a stigma attached to that in society. And people aren't always getting the support that they need. So our training is looking at that as well. And of course, the real skill set around that does often sit in the voluntary community, faith and social enterprise sector. So that's who we're working with in that particular area. But that needs to be an offer across the board. And it needs to be really clear that if somebody working in any setting, general practice, adult social care, VCSE, if they're worried about somebody, that we all know who to send that person to or who to talk to get the right sort of response. And that's part of this work as well, Prince. And I think if we can get that right, I think we'll have a really big impact. But I am mindful that Sarah, with lots of expertise in the room.
Yeah, Lee, I'll just hand over to Sarah and then I'll call you in if that's okay. Sarah.
I'm quite loud, I might not need to, sorry. I think I wanted to just reassure you, Prince, that the work that Andale has been doing and we're doing across kind of the population health and prevention pillar, which links into MHLDA, what we have is a number of different fora across the county where there's actually a wider group of voluntary organisations feeding into both the West Training Framework and potentially the North, because I think that is our biggest challenge. Our biggest challenge is that it can feel very, very frightening and it can be disarming and disabling for those individuals. And that fear of not handling it correctly often then can stop people from taking action. So I suppose I can reassure you that between the numerous different forums we have across the various collaborations, there's a whole spaghetti bowl full of kind of information coming up into trying to make sure that we have got something that everybody can feel comfortable with. And that probably has to be quite tiered, doesn't it, in that universal approach and then that kind of what comes next. But I agree with you, we just need people to know how and where to get support at the right time.
Councillor Duffy.
Thank you, Chair. Following on from what Prince has asked, really, I just wondered what contact you have with outside charities and organisations. So I look at the figures up there and I think, sadly, a lot of that is probably gathered after an attempt is made, or sadly some of them will be successful, whereas charities and local groups might encounter these people before they've actually made an attempt. I appreciate that there's confidentiality involved in that, but I just wondered if there is any input from them or involvement.
Yes, absolutely. We do work very closely with the VCSE sector and our local communities and charities through the MHLDA, through Aspire, North Northants, through Support North Northants as well, and different areas that we do work with. And especially, I think recently we have worked very closely with Kelly's Heroes around Baton of Hope, and I think that was a major campaign that sort of brought all the VCSEs together. And even if there were some that we were not quite aware of, through campaigns like that, we do get exposure to more VCSEs and charities. So it's something that we are very hot on, per se, around working with them. Yeah.
Colin, would you like to come in?
Thank you, Chair. I think just two things. One which partly picks up on a theme to my left here from Councillor Duffy and from Prince in terms of a particular group, and that is about veterans. So we've got over 12,000 veterans in North Northants, and there's lots of evidence to prove that this is, both in terms of mental health and suicide, are a group that are at high risk. So there are national as well as local charities involved, so it's about how we link into that. And clearly there's the Operation Courage work that's based at St Andrews, but it's how is this linking into this conversation to make sure we're both supporting the voluntary sector, our staff, say in the acute sector, You know, the number of people that pitch up at A&E on a Saturday night or a Friday night, you know, that potentially are suicidal. You know, there's all those aspects of it, but I'm particularly focusing in on how we engage with the vets and the vets organisations.
Thank you, Colin. I'll bring Andalay in to answer that question.
Thank you, Chair. We've recently been having some workshops to develop our suicide prevention strategy and action plan, and veterans actually came up in our most recent workshops as a priority area. So through the development of this strategy, veterans is definitely going to be one area that we will look into, and we're looking to work with local organisations that do link in with veterans to make sure that we're having that sort of targeted approach for suicide prevention in that area as well.
David.
I just wanted to add some clarity because there's a really good richness of conversation here. Clearly this is a macro view, but there's a lot of micro interactions to give assurance that we're working as a system together to link together the Armed Forces Covenant, for example, and making sure that all of our Armed Forces Covenant champions, I'm one of those for the ICB, for example, ensuring that people are aware of those risks. Very much small group minorities are the biggest risk areas, so LGBTQ, lesbian, gay, bisexual, transgender questioning is an area, so that's why we invest, for example, in youth groups to make people comfortable in help people be comfortable in their own skin. We know that neurodivergent communities, autism and ADHD, have some of the highest levels of suicide, and indeed we're aware of the challenges in the system, so we're trying to ensure that everybody that works with these groups through things like the PINS program, so that's Partnership Inclusion and Neurodiversity in Schools, or the Oliver McGowan Mandatory Training Programme we have in adult social care and in clinical settings. We've delivered training to 2,500 primary care staff in this area. It's about making people aware of what tools and resources are out there. In children's in particular, we've undertaken a mapping as a part of our SEND journey to look at what we have at the different levels, and that's been shared across the entire workforce in children's in North Hants, so that, again, we can try and close those gaps. There are other elements around workforce, so we know that farming communities in particular and police officers as well as veterans are high incidence rates. So again, we do some targeted work with our partners in those areas like the NFU for the farmers, and of course we have a lot of liaison with the Police and Fire Commission office to make sure that that awareness is there. But the bottom line is that this isn't just one siloed program. This is about our emotional well-being resilience building. It's about community connections and making sure that our neighbourhood architecture absolutely makes sure there's no wrong door. When somebody is concerned, it's about having the right questions. It's about modelling the right behaviours in statutory services, about having mental health first aiders and other champions to speak up to. And it's about making sure that we actively listen to our community partners, be they voluntary sector or otherwise. And that's what we're kind of doing that's behind the data here. But because of the numbers that we're talking about, it's really easy to identify particular families, and there's a sensitivity around that. But I can assure you that those are some examples of the detailed work that we do. So just in Kettering on the Rockingham Road, Johnny's Happy Place is a prime example where they're trained to do peer support for suicide survivors, because we know that they are 5 times more likely to also take their lives. So there's a whole network of people in our happiness cafes and in other parts of the system. There are barbers and hairdressers who also have undertaken training and involvement. So this is a really deep web of support, but these are the right questions in my view.
Thank you, David. And just on a personal level, Prince, to go back to your original question, this is a subject which the team know is very close to my heart. As chair, I've been active throughout the summer in attending events and working with my colleague in West Northamptonshire, Laura Coos. We both co-presented a programme in I think it was in the Guildhall, but no, at the museum it was, at the museum. Guildhall was another meeting. But and I'm undergoing some training in January, which I'm very much looking forward to. So I think if I can provide some assurance around the table that we're taking this very, very seriously. But I'm going to hand back over to Andile because we haven't quite finished this topic yet. Thank you.
Thank you. I just wanted to add on that focus point for males between 45 and 64. As Lee mentioned, it has been a high-risk group for years. And last year, during Suicide Prevention Day, we actually launched a male suicide prevention campaign with West, working with West, and that's what Councillor Bennyworth was talking about when we had the launch event earlier this year. And that was 8 males with lived experience that sort of shared their journey and expressed messages of hope. And the whole campaign is all around starting the conversation and reducing stigma around actually talking about suicide. And I believe that the campaign is actually just a stepping stone and a start for us to sort of push forward around those high-risk groups. So on to our second objective, which is around increasing the focus on reducing smoking in people with serious mental illness. Sorry.
Just before we move on from that, I suppose I just... Oh. Is that on? Sorry. Hello. Just before we move on, I think, I don't know if it's Councillor Duffy who raised the point, there is something probably that's quite important for all of us when we're considering kind of the various data sets. So one of the things that's really interesting is that I know there is some newer data over this last year where we are seeing an increase within our county. So I suppose it's really important for us to have the information around kind of completed suicide and where we can put that post-vention support that you talked about. Kelly's Heroes is incredible at that. But then also those attempts, and sometimes we can miss some of that data, and that's not always our fault. It's around information sharing agreements between GPs and hospitals and acutes, and that's still something I think we're all grappling with across the system to be able to give a really, really clear picture. So I just wanted to kind of, differentiate the difference between those two data sets, really.
Thank you, Sarah. And I think just on what you mentioned around attempts data, again, it came up on our suicide strategy workshop that we do want to be able to collect attempts data so we can have even a further prevention element to deaths by suicide. We're going to work with Lincoln, who currently do collect attempt data, just to see how they do it and sort of take that learning on from them. So objective 2 is around increasing focus on reducing smoking in those with serious mental illness and improving the physical health of those with serious mental illness. As part of the maturity programme, it was agreed to increase the uptake of quality of health checks and also to reduce the premature mortality amongst those with SMI. So as part of the health and wellbeing strategy, we're developing a service spec. We've developed it. It's going through commissioning and the legal processes before we actually put it out there. But it's all around reducing inequalities and raising awareness for improving physical health for those with SMI and also increasing the access to health checks. We're also working on undertaking a co-production work to understand and agree an approach to reducing smoking amongst those with SMI. And this will sort of shape the work we'll do to have a tailored approach for reducing smoking in those with SMI. And we're also speaking to the Recovery College team around developing SMI and smoking cessation training. Next one, please. Objective 3 is all around reducing mental health inequalities related to access, experience and outcome. So the Prevention Concordat for Better Mental Health, which is a county-wide concordat that we signed onto via the MHLDA. It highlights health inequalities plan and agrees to deliver actions to reduce health inequalities for people with SMI and specific communities as well. So earlier this year we published our Joint Strategic Needs Assessment for mental health, all the way from children to older people to pregnancy, so like through the life course, our JSNAs, and we'll be working on addressing some of the recommendations from our JSNAs and also addressing the determinants of poor health and poor mental health. We'll be also looking at early indications for those with physical health risks and improving for reducing the risk of unhealthy lifestyle behaviours and working with our lifestyles team as well. Thank you. Next one, please. And finally, I just wanted to give an overview of our progress to date. We'll be working with a local VCSE around compassionate conversations training for staff in North Northants. So that's around how we speak to people that call in from our frontline staff, people that may have mental health issues, that may have been bereaved by suicide, so that our staff are equipped to be able to signpost them and communicate with them adequately. We're also looking at a scheme called the Orange Button Scheme, which is for those that have been trained, that have mental health training, so that anyone that does have mental health training is noticeable and can be identified by the public by a big orange button on lanyards, etc., so that if anyone in the community sees them, they know that I can approach this person and they'll be able to signpost me to where I need to go if I have a mental health need. We've also been doing some engagement workshops, as I mentioned earlier, for the development of our strategy, which is currently in progress. We've finished our workshops. We're currently in the consultation period, and we're hoping to have our new strategy out by April. That's the current timeline. Suicide prevention escalation protocol has also been updated. So we have one for children and young people and for adults as well, so that everyone knows what to do in the event of a suicide. Suicide audit, as Lee mentioned earlier. And then the other two I think I mentioned around the Inequalities Project and working with the co-production around those with SMI and working with Recovery College as well. And I think that's it for now.
Thank you. Councillor MacDonald.
Yeah, I've been sitting here listening. I'm probably fair guess that I've dealt with more suicides and more encounters than probably all of this room put together, hundreds in my time. I think it's very important when you're looking at your training, and it's for the survivors, for those members of staff who deal with the people, to understand that there aren't always indicators that people are going to do it. I've lost track of the number of ones who people never knew there was an issue. They just decided to end their own life for a whole variety of reasons, mainly because it will centre around the fact that they're embarrassed, they've got pride about the issue where they are, and so they don't talk to anyone. That includes their loved ones. And then, of course, when they do take their own life, those people and their close friends feel devastated because they didn't miss those things, because you have a wonderful list. And then we look down and they just failed to see, they didn't tick any of them boxes. So, I think it's probably to incorporate that in your training, I would suggest, just for our staff and other sector people, just to make it, looking after their mental well-being. That's just my point, Chair.
Thank you, Eddie, and a very good point it is too. I think it's great to have people with lived experience of dealing with these things. I've dealt with it myself, so hence my passion on this particular topic. So, Jane, you wanted to say something?
I just wanted to remind ourselves about the issue around why smoking cessation is so important for people with serious mental illness. So the prevalence of smoking is much higher in that group, but that group on average are likely to die about 15 years earlier than the general population. And there's a number of reasons for that. Diagnostic overshadowing, for example, and also some medication issues can cause an issue, but actually smoking is a major contributor to premature mortality in this group. And we really do need, as a system, to work really closely together to make sure that we're addressing that and giving people the right support and consistent support to stop smoking. It will make a huge difference to people, but it's always a bit tricky. It's never easy to give up smoking. For everybody who smokes and who gives up smoking, that's an incredible achievement that we've got to really applaud. But for those people with serious mental illness, we need to give them the right support, because we can make a major difference to that life expectancy gap.
Thank you. Prince.
Thank you, Chair. Just a couple of things. I think, and what Jane said in terms of that wider outreach and the training, I think it will be very useful, because some organizations are not, experts in the mental health kind of arena, but having that basic training would help a lot. And also just to say that, establishing great relationship, which is the thing within the VCSE and other areas, actually help, because then you body up and then that person opens up to you at that moment, where he would even tell the wife or close, people around them, but because of that engagement. One thing I picked up, sorry, I can't remember the name, the lady who spoke, but talking about visibility in the community, and I was just kind of, thinking about that. Would that be, a pro or a con in terms of the fact that if people are not comfortable in themselves kind of, showing up and somebody is wearing a lanyard, for example, would I be comfortable approaching that person? Or should we have to, probably an alternative way of how could they be a bit discreet or other pathway? But I'm struggling to see how someone with a little pride or not, with a taboo within some context, and then someone with a lanyard and approaching the person because that signifies that I'm having a mental health issue. I'm just kind of raising that to see whether we could look at alternative pathways in reaching people.
Yeah, no, I absolutely understand your point, and I actually brought this point up to our regional suicide prevention team, who I sort of got this, that a lot of them do the orange button scheme, so we got this from them, and I think it's all around people that are trained and confident. You don't have to wear it, you have to be trained and confident to be able to speak to somebody and signpost them. It's not a thing that when you speak to them, you have to be the counsellor, you have to give them what they need at that point. Just being able to point them to the right direction and say, yes, if you need to speak to somebody, speak to this person. And another aspect of it is also those frontline people like hairdressers and barbers, making sure that people that actually speak to people on a day-to-day basis have that basic training and are able to signpost. It's not that we should be able to deliver counselling or be able to deliver mental health support, but being able to actually say, okay, you should speak to this person, you should speak to that person. That's the element of it.
So just a quick one. It's not about the counselling and that. I'm talking about the visibility in terms of a lanyard on the hairdresser's neck and in that community, or a barber shop, and then the lead person is wearing a lanyard, and I'm sitting there having a haircut. I'm not going to talk to that person because I'm thinking everybody around me is going to see that I have issues. That's what I'm referring to, Chair.
No, I understand what you're saying. I think the campaign will come with a comms plan as well to make sure that this is actually out there and people know what's happening, people know why this person is wearing a lanyard. If you want to contact, speak to them, you can do. Yeah, so it will come with a comms campaign as well. Yeah.
Prince, I'm going to come to Sam and then Sarah, and then I'm going to wrap this item up because we've run way over time, but for very good reason. So over to you, Sam.
So I did pick up that was your point, that why would people engage with people wearing a button? And I think some people might not engage with the concept of people wearing a button, but some people might. And actually, I think what it is, it's strength to the armoury of resources that enable people to have a conversation with somebody in that moment that can offer them some time or some advice, or even break that thought process that takes somebody down a different path. And, I think the more that we can raise the prevalence, the more that we can do, your barbers, your people in the coffee shop, they're the people who can say, actually, do you know what, I've seen somebody wearing that button. You could talk to them. So I get it might not be something that people proactively, but I think for some people it might be that little switch that says, maybe I should just try speaking to somebody. So yeah, I just thought that it's helpful. I like with a lot of these campaigns that visually prompt people to think differently, the Ask Angelas. I personally think that for some people they will reach out and engage with that in that moment. Thank you.
I suppose in response to what Prince has said and also what Jane and yourself are saying is that actually what we want to do is create communities and cultures where everybody feels comfortable and confident in discussing such a difficult but very real issue. And so for us, there's something about that lobbying, that providing a number of different ways and forums. And what we see in employers when they approach us, both through Northamptonshire Mine and through the mental health collaboration, it is that fear that you described, Jen, that nervousness that people have around a difficult issue. Will I make it worse? Will I say something that makes this difficult? And actually, until we start to roll out really kind of broad spectrum training, it's a bit like if we think back 20 years ago to safeguarding, this idea that we're all responsible for that. I think that's really what we're all aspiring to do, and we know that that will be layered. We're not trying to create an army of experts, but if we think about the impact of the low-level mental health funding, your community champions that are out in food larders and in banks and in libraries that are members of the public that are volunteering, we're not trying to replace our clinicians. We want to really grow that knowledge and confidence. And I think that's really important. All of us have part-time workforces, staff. We can all have an impact. So... Oh, sorry, I'm getting on my lobbying horse. I just think it's really important. So it's exciting, yeah.
And I don't think anybody in the room disagrees with you on that particular point, Sarah. But I'm going to bring this item to a close, but I just wanted to thank everybody for their input and their passion around this subject. There's, undoubtedly, there's a way to go, and in my personal view, suicide is everybody's business, and we should all be alive and be able to reach out and be able to signpost. I think it's a life skill, just like swimming. Anyway, I'll get on my hobby horse. Lee and Andale, thank you very much indeed for that item and for generating such rich and good debate. So the board is asked to note the progress on the health and wellbeing strategy and also the update on mental health. I think we can all safely say that that's been achieved, and we can move on to the next item. But thank you both very much indeed. So I'm going to move on to item number 9 now. This is our draft family help strategy. Following disaggregation in March 2025, a local authority family help partnership board was formed and a family help strategy has been developed, the draft of which the board is asked to consider today. Feedback from the board is sought to help shape the policy direction and resource allocation from a multi-agency perspective, and I'd like to invite Judy Matthews to present the draft strategy. Over to you, Judy.
Thank you, Chair. This draft strategy is the final draft to come for your approval and sign-off today, with a view to us publishing it and launching it officially at the end of January. Some of the terminology may be quite new to you, as we're using the term family help, and you may recognise it in old money as early help. It aligns with the statutory duties, social care functions that are coming in from next year. We're really keen in North Northamptonshire to ensure that we have a family help strategy that meets the needs of our local families and not from a county-wide perspective. So from March this year, we moved away from having a county strategy across North and West, and each authority was requested to develop their own family help strategy. The strategy that's been presented to you has been co-produced with numerous partners across the voluntary sector and other agencies in North Northants, and it also reflects the voice of children and families to make sure that what we're presenting to you is going to actually address the needs of those families. So family help is about giving help and support to families at the right time. And it's really about intervening at the earliest opportunity when those presenting needs arise. It's not something that is just the local authority's responsibility to deliver, but it's really a partnership approach. So anybody that comes into contact with families in North Northamptonshire, whether you're in a school, whether you're in an A&E department, in the library, or any of the services that we deliver, it's really important that we're all skilled to identify those needs and then provide the support to those families or signpost them to that support. Excuse me. Why do we need family help? We know lots of data tells us that, poverty, child poverty is on the increase. We know that we've got an increasing number of different communities moving into the authority. We have certain data sets within public health that indicate that immunisation rates aren't as high as they should be. The take-up of 2-year-old checks are not as high as we would like them to be. And that 17% of school-aged children have SEND. And if we can identify those needs and put support in at the very earliest of opportunities, the opportunity for those children to thrive and achieve to the best of their abilities raise significantly. And also, hopefully, there will be a reduction in social care interventions arising further down the line. So how does this strategy fit in with other approaches? As I said, the local and national context aligns with our corporate priorities. It also aligns with the new social care reforms that come in place imminently, and they will be familiar to you, probably known as the Family First initiative. We have ensured that we have heard what children and young people and families have told us. So we've been advised by them that they want easier and quicker access to support. They want places where that they feel safe that they can go. So our family hubs are quite key in this delivery model, but also our young people are quite vocal in the fact that they want access from services that provide youth services, so youth centres or some of the voluntary sector groups that provide the support for those children and young people. Our vision is that we empower every child and family to be the best that they can be. And at the heart of it, our family help model is a shared vision to give families the right support at the right time by the right person. And we do this by focusing on the strengths of the family. So in line with the Northamptonshire Children's Trust approach, when working with children and families, the team follows important values like keeping people safe, building trust, working together in order to make that real difference. The model is taking more of a linear approach. So when families come into services and access universal services, staff will be equipped to identify those needs earlier on, to build that trust with families, to enable them to feel safe to approach and say, I actually need help. And that member of staff will be able to stay with them right through their journey and hopefully stop escalation into social care interventions. We have set out 4 priorities. Sorry, just lost my... one is about locality-based, inclusive and accessible support. So the family hub model that we've developed is quite key in this because it's delivering services right in the community in the heart of the areas that families live in. And our family hub networks are not just about one space, they're about a variety of space. So it might be the local school, it might be the community centre, it might be the health and leisure centre. So services are delivered robustly across the whole of the locality. And that's really important for families so that they can get that service right near to where they live. We're taking a think family approach, so not just focusing on the needs of one member of the family, so not maybe one particular child, but looking at how those needs impact on the whole family and putting a package of support around all of them so that we can really evoke that change and make a difference. The right support at the right time by the right person is quite critical, and so we're embedding quite a lot of workforce development across the whole sector to ensure that staff are skilled in early identification, but also in some of those support practices that need to be put around those children and young people. And the last one is around family's voice. So it's very important that throughout all of this we hear the voices of children, young people and families so that we can develop services that meet their needs, based on what they tell us and not actually what we think they need. We also have developed 10 outcomes so that through all of these interventions we will be able to report back to you as a board on the difference that we've made and how those impacts are being measured across the system. that's kind of the outline of the strategy, and we've brought it here today as this board is seen to be our accountable board in the governance structure. So as I said, we circulated the strategy prior to this meeting, and it is the final draft, but we would welcome any feedback or any queries or anything you'd like us to include in that final draft before we send it to print and then have an official launch at the end of January.
Thank you, Judy. So I'm assuming that everybody has had a look at the draft. Just quickly from my own observation, there appears to be, I think on page 51, some bits that he highlighted in yellow that haven't been completed. So it's mainly source data, I think, but there's some missing information. So I'm just encouraged to get that populated. But I'll just move over to Councillor Trevor Conway.
Thank you, Chair. Just quickly, the report was good, really good to read. I'm just wondering, though, in the report, you're referencing young people from 0 to 19. Why are we going up as far as 19? As far as I was aware, young people were deemed as under 18. So it seems a bit counterproductive to be including another range of people that we wouldn't really deem as young.
Within all of the statutory duties that we have, it's 0 to 19 and 25 with SEND. So the early help spectrum and all of our children's services follow that spectrum and age range.
Thank you. Thanks, Judy. I think for me, this is one of the clear areas of work where no single part of the system can do this alone. And I think there's a couple of really fantastic visuals within this report. There's one that's like a honeycomb in the early part of the report that shows just how many services need to wrap around families to get the best possible outcome. And I think that is the real thing that we need to get right for this is how do we make sure we do that together. Now, for me, obviously some of the services in that honeycomb I'm responsible for, and it's really great to see that coming together. So the family hubs for me are a really good way of integrating services around the family in a way that I think some of us who've been around for quite a long time, myself included, can remember that sometimes we had this through things like Sure Start a number of years ago. Actually, it's really nice to see that coming back for our communities where we're going to have that thing about the right time, the right person, no kind of wrong question for the wrong person. You can get that support when you need it, and you can get that in either a virtual space or in a physical space. I think that's really, really exciting, Judy. And I think what we would need to do as a board is make sure we're all playing our part in that, because I think we're all represented in that honeycomb, Judy, and making sure that we get that right.
Prince, over to you.
Yeah, thank you, Chair. I think the Family Hub is really serving a very great purpose. I think for me, it's how then do we collectively, just to follow up on what Jane said, make sure that our families are actually engaging with the Family Hub. And I think that is a crucial bit. So we can have all these things happening, but if we don't get that, families engaging and using that space to actually serve the need and just have that impact, then we'll be falling short. So I think, how do we do that collectively in that sense?
It's not just about a family hub, though. I think that the strategy is very clear that it isn't just about a hub and a building. Within that honeycomb, there are schools, GP surgeries, dentists, shops, Cubs, Scouts groups. They all are a point of contact that you wouldn't want to miss with a family. And we do have a robust digital offer as well, but I think it's everybody taking responsibility for ensuring that if somebody reaches out and they say they need help, that they take them on that journey to get that help. And the Family Hub might be a mechanism to get it, but it wouldn't be the only entry point. So basically, any door that a family goes through should be the right door.
Thank you, Judy. Anybody else want to have an input? No? Oh, happy. So, Judy, I think from myself, the key thing for me, I'll go to the board in a moment about sort of approval, but if we can make sure that those blank areas are filled in. My other feedback is that in some parts of the strategy there are acronyms which I didn't understand, and so if somebody could take a look through those, because if a member of the public picks up on that, they may not recognise what the 3 letters mean. So I just wanted to provide that bit of feedback.
Thank you. I think we put a glossary on the back, but I think we probably need to expand on it a bit more, so we'll revisit it.
Yeah, that would be great. And then I think the final question for me is, from a board, is how we monitor this strategy. So we've got measures and outcomes in it, but I just would like to throw that question out to the board in terms of inviting Judy or colleagues to come back to give us an update on how this strategy is being implemented. I don't know what you would feel comfortable with, because it needs to be operationalised and that can take some time.
So tomorrow we've got a workshop with all the partners coming together to look at how, as a partnership, we pull together an action plan. So it might be that action plan can be monitored and reviewed by this board, so we'd be happy to bring that back to you.
Okay, if we can take that as an action then, Lisa, that I'm actually part of that meeting tomorrow for a short period of time, so the board can be rest assured that we'll have a presence and an input into that action plan. So thank you very much. Sorry, Sarah.
Well, it's just a quick question. It's, I mean, it's brilliant to sit and read through it. I was just checking. Just checking the strategy. We all know we want to take it from page into practice. I'm assuming this is a document. Is this a document written with the intention of it being for professionals, and then there will be a shortened or a slightly different version? I'm not asking necessarily about the comms strategy, but I'm a bit like you. It can feel very long and lengthy, and I'm not knocking it up, but it's taken a long time to get it to this.
Yeah, it's been written in line with the reading age of 11, so it's been written in that way, but it is quite lengthy. So we would anticipate doing a shorter version and a bit more succinct version, but it will be able to be uploaded and published straight away with because it's been accessibility checked, so that's a positive too.
All right, thanks.
That's great. So we'll bring that item to a close if everybody's happy with the actions that we've taken. So we're going to move on to agenda item 10, which is the SEND Joint Commissioning Strategy. The SEND Joint Commissioning Strategy sets out a shared vision of the way in which organisations with the SEND local area partnership can collaboratively commission services to best meet the needs of children and young people with special educational needs and disabilities across the North Northants area. It identifies key priorities for partnership commissioning activity and agrees a shared best practice approach to this work. The board is just asked to note the progress and return to the board for approval once the delivery plan has been populated. So to introduce this item, I'm just going to hand over to David. Is that correct?
Yep, that's right.
Okay, thank you.
So apologies for Matthew Jenkins, who chairs the Joint Commissioning Group. He's on annual leave, and Troy, who's our SEND lead for North Northants. But I think it's a wonderful opportunity as a health partner that demonstrates the true systemic work that we're trying to do together with the Children's Trust, with health partners, public health, education, social care. And that's the whole focus of this, is that children and families are not in their isolation. And this leads on very nicely from Judy's report, because it's about trying to take that joined up approach towards making sure that they get the right support, rather than saying there are various channels of funding or governance that can sometimes get in the way of getting the right outcomes. So this is about, with an ever-increasing level of demand across all the areas, with a very finite level of resource, not just in terms of cost, but in terms of training, skills and expertise. There's not enough of these experts in the country to do the work that needs to be done. This is about a way of trying to work smarter and Prince has asked some fantastic questions today that is really the rationale behind this strategy. So what this is it is a governance commitment amongst partners that we work together out of our silos to try and expand and diversify what local services and provision we have available. Some of those will be directly commissioned from our budgets as statutory offers, but some of those will also be about working with communities and neighbourhoods around mobilisation and building assets, creating opportunities to make sure that the data is available, testimonials, so that we can bring in revenue from other channels in addition to what we commission, so that we can make sure that we meet the needs of our population. The focus on a lot of our services, sadly, are at the later end, and as we know, a lot of our SEND families, before they ask for help, are already at crisis point, and then we continue to traumatise that experience through a number of years, in many cases, of navigating through the special services until they kind of maybe get an answer, and at that point we've done some damage. It means that there's a lot more work that's required afterwards. It's a lot more costly, and the economic and social outcomes for those individuals is proven in the evidence to be diminished. So this is about trying to invert that and going, okay, if we go back to our suicide conversation earlier, it's about what are the themes around the core competencies that our workforce need, both our formal practitioner workforce and also our volunteers and community leaders, to make sure that the right tools and skills are there to have those conversations that goes, actually, have you spoken to so-and-so? They've got a really good handle on that. You don't need a piece of paper around that. Or being able to say, actually, yeah, I'm afraid that one does need some medical intervention. Right, this is the best way to get on that pathway. And we need to do this together. And to enable us to do that, we need to understand our data. So if we look at the joint commissioning or the JSNA that we're currently developing, the Joint Strategic Needs Assessment for SEND, we are looking at the population needs, and we know, for example, anecdotally, that 66% of kids that are presenting for autism or ADHD assessments that are white British get a positive outcome, as in they get a diagnosis of being autistic or having ADHD. That's compared to a 90% average across the country. So we have a lot of white British families presenting that aren't actually autistic. They have unmet needs. On the flip side, we have a lot of non-white folks that are presenting, where 95% of them are getting a positive yes, and then they're backing away from services. And so there's this work that we need to do to really understand the needs of our population, and not those that are shouting loudly, because there's a lot of noise and there's a lot of mythology in this space, but using a strong evidence base around our collective decision-making to improve the outcomes for those that need it the most. And then what it's about is making sure that we've got a really equal way and transparent way of doing business. So it's no good one particular department going, right, we're not going to commission it anymore and not talking to anyone else, and we only find out once it's been implemented. It's about actually thinking holistically to go, okay, if we need to change this, what's the impact that it has on that? And how do we get that right first time? How do we have a no wrong door bit? And how do we make sure that there's no decision about us without us, which is our commitment in the SEND journey, about making sure that parents, carers and young people are absolutely a core part of designing and monitoring the quality of our services, not just consulting with, we do that to death, but actually real meaningful co-production. So the strategy puts that all together as a commitment as partners, and it's been agreed in terms of the governance through the SEND Improvement Board. It's been endorsed within NCT. It's been endorsed within the Integrated Care Board. So what we're doing is bringing it to you as a Health and Wellbeing Board to endorse, and to the annex in this particular paper shows you the tools that we're going to use to try and drive this through. So we do want a steer in principle of how you'd like to see this moving forward. In terms of the resources, we're using the existing resources that we have amongst partners, so there's no additional financial cost, only a time allocation to that, and there's no significant legal risks, but the benefits we think are quite large. There's no need for scrutiny as a part of this process unless we're told otherwise, and actually we think that this may reduce our carbon input, because what it does mean is that we're not duplicating lots of different effort and that we can align our work programs much more effectively. The tools and the mechanisms, we meet currently monthly. as a joint commissioning board, and that consists of the members that I've talked about before. We are extending our invitation to the Office of the Police and Fire and Crime Commission because we think that's really, really important. And also we're looking at how we can better enable our voluntary sector partners to get on board. And so we're talking to Groundworks, for example, who's our main partner in the north, and also in engaging with our parent care forums and our youth parliament or youth assembly. The tools that we want to use, because the strategy, you can write many, many strategies and they can sit on a shelf. The reality is, how do we demonstrate that we're delivering our promises? How do we show our progress? This is a really difficult journey. So it's like hiring a Sherpa on your trip up Everest, where they keep showing you how far you've come and being really honest. Yes, we still have a long way to go, but at least you've got that way of monitoring it. And that's exactly what this delivery plan is about. So you'll notice it's light on detail. This is just a framework at the moment. We've started putting some real skin on the bones this morning, and we've got a few more sessions through the last quarter of this year. And the intention is that we really use this in anger in 26-27. And the whole idea is that the governance is really clear because there's a lot of duplication in the Northamptonshire system and in the Midlands system. So this is about trying to pare that down so that we can best use the capacity that we have. And that's what the governance section is dealing with, and we're tightening. It's around making sure that our data and evidence is clear, that we're trying to remove the barriers that Sarah already talked about in terms of information sharing agreements, and making sure that we've got a common language, a common set of numbers. And as a part of the Send improvement journey, this was asked of us. Unfortunately, it had been put in abeyance with some of the leadership changes. We're now bringing it back out and polishing it off and trying to get it back up and running again. So we'll be using this document to help track some of that activity. There's the element, again, within that around the communications and engagement bit. So it's coming back to that point that, for example, most of our stakeholders use TikTok. I'm not talking about the kids, I'm talking about their parents, particularly the ones of younger children. And yet in local authority and NHS, we're resistant to using those tools. But it is the channel that they most engage with. NCT, however, have a wonderful protocol where they use it, and also our voluntary sector partners do. So what we're talking about is having a multi-level communications approach that sits within this group, that is jointly developed with young people giving their voice, with parents and carers giving their voice, and as professionals moving away from massive tome-like documents and things that are much more easily digestible, with the big tome sitting behind it if somebody wants to dig into the detail. So this is about absolutely steering that course of action and making sure that that's a part of it. And if I'm really honest, our Parent Carer Forum, they've been doing a lot of hard work. They did their survey. As partners, we haven't formally responded to that yet, and I do state yet. And also they're doing a festive check-in right now with families, and they've created a Padlet, which is a form of tech where they can put their thoughts in. And it's kind of sad when you read the comments that are coming in, because there's a lot of good work that's taking place, but as we agreed as officers this morning, there's no point in it if nobody is aware of it. So what we're trying to do is distill this into a much better communication strategy and plan that is delivered across all the partners together. And that is as important as the actual delivery and the commissions themselves, if not more so. So what we found in our mapping exercises as a part of the Send journey, for example, is there are hundreds of services that we commission together to support this cohort. The local offer that Judy's team oversee, they try and keep everything in order as best as you can with the number of variables in there. But the amount of professionals, let alone families, that go, there's nothing in my area. Or someone in North Northants actually said to me, oh, well, it's much easier if you're in Northampton if you're autistic. And yet North Northants has 5 times as many youth groups as West Northants does. So it shows we've got a lot of work to do in terms of communicating in an effective way. The funding and innovation is key. I think the risk that we all recognise is that as budgets contract and demand grows, there is this habit that we often have of retracting to statutory, when actually innovation is what's required most of all. And we don't always have the freedom within our governance or finances to innovate in the way that we wish to. So this is about actually creating that way of going back to Prince's feedback about how do we meaningfully work with neighbourhoods. How do we work with the family hubs? And how do we bring these opportunities together to seek other community assets and really optimize that delivery. Or if there is something that we're doing in an education setting that sets someone up for their life, how do we make sure that's in our ordinary available provision, as we like to call it in education? But basically, how do we make sure that's business as usual for every young person rather than just one particular cohort where we're piloting one way of doing things in 1 year? So there's a lot of work around that sort of aspect. The transitions bit is another challenge. So there's elements around the needs-led commissioning. So what do people need? What are those pockets? And we're not going to go into detail today because I could probably take up the whole meeting doing that, and I shan't. But it is about actually looking at what are our needs and how are we tackling that. With the early years of inclusion, we know that pre-birth is where it starts, and those first 1,001 days are critical. We're all signed to that as partners. But then the transitions after that. And we think of transitions often as going from preschool to primary school, going from primary school to secondary. Yes, they are. We think of it in terms of going into adulthood. So Councillor Conway asked, why do we have a 0 to 19 service? Well, I'm sorry. Unfortunately, we don't have it all nailed down by your 18th birthday, particularly if it's very complex, or you've been lost in a large system. So that's why we have that cover. That's a huge transition. But then we have the episodic ones. We have the bereavement. We have the suicide. We have the loss of a job, domestic abuse, adverse childhood experiences. So this is about, these are the bits that in my 30 years in the sector always get talked about with very little action because there's other big ticket items. This is about making sure that doesn't happen. And then what we've got is things around the workforce capacity, making sure that we've got the right provision in place. Is our market, where we're commissioning externally, able to meet the needs that we have? We know in education, this is a significant challenge. We know with foster care placements, a significant challenge. With complex health needs, a significant challenge. So this is about trying to make sure that we can work with the market, and as we get our crystal ball out and look at what we're going to need in the future as well as today, that we've got a market that's fit to meet those needs at a price that we can afford. And then making sure that we've got those outcomes so that we're walking the walk, not just talking the talk. So it's about actually being able to say, right, this is what we've done, this is the impact, and the bit that gets us all out of bed in the morning, and this is the so what, this is the difference it's made. And then how do we make sure it's sustainable and it's not dedicated on the wonderful professionals we all work with, that as we move and things change, there's consistency for the families that continue to live and hopefully start to thrive in our communities. So this is a very bold way of trying to pull together the different threads in the system that often unravel without those controls, and give us a level of control that we as partners all own, and that we use the Health and Wellbeing Board as the mechanism there in consort with our Children's Transformation Programme and our Mental Health, Learning Disabilities and Autism Transformation Programmes, as well as the SEND Transformation Programme, fitting those all together so that by the time SAM services inherit these young people, for example, we've given them a better start into their adulthood. So what I'm asking the board today to do is to hopefully endorse the direction of travel, to give us recommendations of things that you would like to see. If we've missed anything, please don't get bogged down by the detail. This is the starter for 10. But please do send us through anything that you think, and Matthew and I will work with our colleagues to try and shape that and come back and report as and when you would like to see us.
Thank you, David, for that very comprehensive run-through. I'm very conscious of time, so I'll just take a couple of quick questions, and then I'm going to wrap this up because I think David has asked that we feed through to him, and then I'm going to take a quick comfort break. So I'll start with Prince first, and then I'll go to David.
Thank you, Chair. Just a quick one. I'm not going to mention all the ones. Just I'm going to pick one. You mentioned that collaboration with Groundwork in that sense in terms of the work. Also, you mentioned about 95% kind of not engaging from the other, not the why. So in terms of that, would you also be seeking to have a diverse organization from the minorities to kind of engage with you on that level, to look at the scent within those families and in that context? Because one thing I was told was a family that had got a child with scent, but they don't know what to do. They are just stuck, and it's a black family. So again, it's how then do we make sure that we get our voices on board as well, but willing to kind of engage from you as well?
Yeah, no, I mean, Absolutely, Prince. I think this is a really early stage. So we only had our third meeting today. So we've been doing this for 3 months. So it's at the very early stages of this group. But it is about making sure that we've got that representation. What I would want to do is make sure that we fit that representation in the absolute most optimal places. So if it's in multiple parts of the send journey, great. If this is it, that's great. I think what would be useful is for us to have a discussion offline and with other colleagues and look at how we can best maximise that input, because that is absolutely an area that we're all joined up that we want to improve on.
Thank you, David. And over to the other David.
Thanks. Thanks, David. I'm just checking what we're signing off here. So, it talks about kind of recommendation that we approve this strategy for publication, but it's very draft as you've described, David, I think. So, what exactly is the board doing with this document today?
Okay, now that's a good question, Martin. I'm not sure what papers have come before me. Like I say, I'm deputising for the chair here. So I understand that the draft strategy had gone out to the board, although that's not on this paper.
Okay, so it's a draft. It's a draft position is the thing that's been asked to.
That's right. Yes.
Okay.
The principles that we're following. Have we missed anything? Is there anything that we need to alter course on?
So when would we be signing off a final strategy? I'm just mindful of the send improvement boards and their activity. When would we be doing something that's in a final position?
Well, what I would suggest is if people haven't seen that the actual strategy itself, that we make sure we remedy that situation post-haste. I don't know if that's something that the board would be comfortable doing offline with the pitch here, or if that's something that you'd like us to formally bring back. That's something you'll need to set the direction for us on. But this is about the principles largely, and I had been under the impression that you'd all had the actual strategy in advance.
I can come in on that, David. I didn't want to interrupt you, but from my own perspective, I wasn't happy to approve the strategy in its current format. And I think particularly I would like to have a look at the delivery action plan, so to see the thing in its entirety.
Okay.
So I was going to suggest that to the board. So I don't know whether it covers your question, but it was a concern that I had when I read through the paper yesterday. Kate, just take one question and then.
It was around one of the principles, so off the back of what David said, around the time and how quickly this is actually going to move forward, because on the timeline box there are no dates, and actually for families that are living with this, we are every day, as I know we all know, but we are creating those traumas down the line. So could one of the principles really be around moving this forward as rapidly? I mean, I know it's complex, but still, if you've got it there as a key thing that maybe we can help support with as a board, because,
Yeah, I mean, that's a fair comment, but as I restate, this was the very, very first draft, so this is the skeleton. So today we've started putting dates in. Yeah. At the same time, there's a number of interdependencies that will affect the dates. So we're moving in health, for example, towards a lead provider model, where we're bringing together 48 different service strands from a number of providers. So those are things that we're needing to weave in, that if we put dates in now around that, and we don't hit those marks that are out of our control. So I do understand, and we're a send family in our household as well, so we live and breathe it. But that's why I said please don't get head up into the detail of the action plan. This is the very first outline. We're populating that now, and there's an even further populated draft that we spent time on this morning, and we're continuing in January on. So we are working at pace. The key thing is making sure that the pathways at the moment, the things that actually make a material difference to people, that's where the concentration of a lot of the effort is of the workforce around this at the moment.
Okay, so if I can summarise, Lee, I'm very sorry. I did say that I would take Kate's as the last question, but I'll speak to you in the break. I think what we're saying is the direction of travel is fine. We note it. We we would like to see it come back in its fullness with the action plan, with the dates populated. I think that's where we can get some assurance, and we would just encourage to do that as speedily as possible.
Very good. Thank you very much.
So I'm going to close that item down now, and I'm going to invite the board to take a short 5-minute break. Just grab some water or take a comfort break, and we'll be back in 5 minutes for the next item. Thank you. Okay, thank you everybody for returning to your seats so promptly. We're going to move to agenda item 11 now, which is the North Northamptonshire Better Care Fund Q2 performance report. And just for a reminder, the Better Care Fund has been crucial in supporting people to live healthy and independent and dignified lives through joining up health, social care and housing services seamlessly around the individual person. The Better Care Fund achieves this by requiring integrated care boards and local government to agree a joint plan owned by the Health and Wellbeing Board and governed by agreement under Section 75 of the NHS Act 2006. This continues to provide an important framework for bringing local NHS services and local government together to tackle pressures faced across the health and social care system and drive better outcomes for our people. And I'd now like to invite Samantha Fitzgerald to present the report. Over to you, Sam.
Thank you, Chair. I will be relatively concise. So this is our Q2 update, and it feels like many moons ago that we were back in the summer months. So just thought it was important to kind of highlight this is the Q2, so July, August and September, when it was nice and warm. Thank you for the introduction. That was really helpful. What I was just planning to do was to kind of just focus on the key metrics, just for people who might be new to the Better Care Fund. You won't be new for very long because I do this at every Health and Wellbeing Board. So I bring a quarterly update. I also bring the planning templates for submission and then the end of year report. So you will become really familiar with the Better Care Fund. So as said, the board has a duty to sign off, which happened at the beginning of this financial year, and then to monitor the performance against three key metrics that we measure. So one being avoidable admissions to hospital, the second being delayed discharges from hospital, and the third being admissions to residential and care home places. So I'll just briefly run through each of those metrics and let you know how we're doing at Q2. So in relation to unplanned hospital admissions for those over the age of 65, really important. We invest a lot to make sure that the right people go into hospital and not those that can be safely managed within the community. So for Q2, we are on track to meet the target, and in fact we're slightly ahead of performance with 47 avoided ahead of plan. So that's quite a positive trajectory and actually quite a change round from Q1 where we were not on track to meet the target. And we would attribute that to some of the schemes that we've got running within our urgent and emergency care board. So actually some of the additional equipment that we might roll out within the community, particularly for people who have non-injurious falls. But we've also rolled out our I Stumble app to be used by clinicians to safely say whether they will be able to lift somebody up or not. So that's really supported in us supporting the delivery on that metric, as well as things like increased capacity to our urgent response capacity, which we've increased by 47 calls per day. So that's some of the metrics there. So at the moment we're showing quite a positive trajectory around the first metric. The next metric is in relation to delayed hospital discharges, and we measure this from what they call the discharge ready day. So actually when somebody's been clinically optimised to be able to leave hospital and they're not able to go straight home. So again, during this period, that was we were on track to meet the target, and we were achieving about 82% of people going within the agreed time frame from their discharge ready date. We'd seen a slight improvement for those that didn't go on their discharge ready date. It was broadly somewhere between 6.5 days from their discharge ready date. And although this is a positive metric that we're within the tolerance, I would say locally we've set ourselves a higher ambition. So actually we've set ourselves a target of 5 days, and very much that is a target that we want to, one, hold ourselves to, but also proactively work towards reducing that. So I think I've spoken before here about the different pathways that we have. So some of those pathways we will be looking at same day, next day discharge, particularly pathway 1, and then just a nod to kind of some of the investment that we've put in through the BCF and other schemes to make sure that we've got that right capacity. So we have done some targeted work on Thackley Green, increasing the level of acuity and making sure that we've got that occupancy really high, but more importantly, that length of stay really low, so we get that turnover and flow, which enables us to have more capacity. And then I did mention it last time, but we've also opening 29 additional beds in Pathway 2 with our colleagues in NHFT, and I believe we're still holding 7 of those back for the post-Christmas surge that we know that will come, so that we can manage that capacity. So on the whole, in relation to days discharges from hospital for Q2, we were on track to meet that target. The last metric is around permanent admissions to residential and nursing placements for those over the age of 65. Now in Q2 we are showing that we were on track to meet target, which again is an improvement from Q1, where we'd seen, particularly in April, quite a high level of admissions. What I would say is this metric quite often changes retrospectively, and that's because it's quite a lengthy process to permanently admit someone. So from looking at our data coming through between Q2 and now, this is a metric that we need to watch quite carefully. I think I have a level of confidence that we're doing the right things within the system to try and keep this metric on track. And again, that links to Thackley Green in the additional capacity and the work that we're putting into people to promote independence, increase their outcomes, and ultimately get people home, which is why this metric is a really important one to watch, that, we are getting good outcomes for flow and hospital discharge, but we're also getting good outcomes for people. So I think overall, positive picture on the metrics for Q2. As I said at the beginning, we are now in our most challenged months. Eileen will know this better than most people around the table. There are 6 pillars with work going on at the moment to ensure that we try to get through winter as best we can and keep people safe. I will pause there, and then I was just going to give a bit of an update on what's next. And I don't have all the answers to what's next, but I think it's important that Board are kind of cited on potentially the next steps in relation to the BCF. So I'll pause for any questions.
Any questions for Sam from the Board? Eileen.
Thank you, Chair. So not so much a question, more of an endorsement of what Sam has presented. I think it makes a real difference. There's always more we want to do with the BCF and going with the changing tides, and I'm sure Sam will come to that. But I think it's been if you look at Kettering, and I'm sure Kettering General colleagues would say this, the interface between KGH, Sam's team and other parts of the system has been historically really strong. And where our local hospitals have perhaps struggled, I think the fact that relationship is there, and these are the schemes that are really almost seamless. So it's not about which organisation you sit in, it's about what the patient needs, is why I think KGH has done better than it might have done in previous years, and it's because of that relationship. So it's really to say always more we can do collectively and also from the ICB, but I think this is, given the backdrop of how hard people are struggling across the entire country, I think credit where it's due. Thank you.
Thank you, Eileen. Anybody else before I invite Sam to continue? No, Sam, you're free to go ahead.
So it's this time of year. So the BCF's been around since 2015. And I know we've had conversations here in the past about, do we want to refresh it? Do we want to look at some of the schemes? And we do that on an annual basis. We are expecting the BCF guidance to drop. It hasn't landed yet. It usually arrives about the week before Christmas. However, I was at a conference week before last, and there was some conversation about the BCF. So what I do know is that the BCF for 26-27 will continue as it is currently, but to use that year, so I'm waiting for the guidance to come out, to prepare us for what's next for the BCF. And the nod that I was given, and I'm sure colleagues around the room have heard similar, is it is likely to link quite closely to that of neighbourhood health and the kind of direction of travel in the NHS 10-year plan. So I just wanted the board to be cited on that. So we will wait for the guidance to drop as we normally would. Once that lands, I can either do a written just note out to the board to say this is landed, this is the direction of travel, if that would be helpful, because I'm just really cognizant that our next board meeting will be in March, and we'll probably have quite a busy agenda. But I think it was going to be really interesting to see what that direction of travel is. So, yeah, waiting optimistically. Thank you.
Thank you, Sam, for that early sight. And I think on behalf of the board, I'd like to take an action away for you to drop the board a note once that guidance does arrive. I think that's a very proactive thing to do. We can be cited on it. Are there any other questions on the Better Care Fund report from Sam? Not seeing any questions. So the board is asked to approve the Better Care Fund performance report for submission to NHSE. Could I just have a quick show of hands in favour? Any against? Any abstentions? Okay, I think we can take that action, that you can submit, Sam. Okay, moving on to agenda item 12 then, the Family Drug and Alcohol Court update. For those of you that did attend the July meeting of the Health and Wellbeing Board, you may recall that we saw a presentation, and a very good one I thought it was too, Rachel, on the work done by the multidisciplinary Family Drug and Alcohol Court team. At that meeting, we asked as a board for an update after 6 months, and this report gives us that update and gives us an idea of how work is progressing. So I'd like to hand over to Rachel Saunders to present this report.
There we go, it would help if I could work the mic. Thank you very much for inviting me back. I can't believe it's quite been 6 months. So, and we're still in our sort of baby FDAC phase. We're 8 months now into our first year, but really it's been busy and fast-tracked the last 6 months. If you could go to the introduction slide, that'd be great. Thank you. Next one. Here we go. So Family Drug and Alcohol Court is a problem-solving approach to care proceedings, and it's voluntary for families. We're funded by North and West councils through the Northamptonshire Children's Trust, Police Commissioning and CGL services at the moment, and hopefully looking to expand that over the next couple of years. But we work really, really closely with our local community partnerships and community groups, and very wide range of services at present. The idea of FDAC is to reduce the adversarial approach to care proceedings. For those who weren't here last time for me to yabber at. We understand in Northamptonshire that care proceedings is incredibly stressful for parents, and we needed to do things a little bit differently and really help those parents kind of engage. And I think we've definitely seen that happening, and we've not had a parent not come to court hearings at the moment unless they have been exceptionally unwell, and only one parent. And even if parents have been really struggling with their mental health or real difficulties, they've came to court, if nothing else, all week. So that's a really amazing thing that we're seeing, that kind of engagement. I'll come on to the team. Next one, Sorry for the photo. So the exciting news is that we have a house. We are based in Swanspool in Wellingborough, so it was really important when we were talking about building FDAC that we were very central to the county. We need to have accessibility for families on both sides, but we do travel out into both the North and West counties, and we use community buildings. Police services have really kindly offered voice and bridge and S2S services, so we use all of those buildings still to make us really accessible. But this is going to be our place to conduct our sort of therapeutic assessments with families. So this is my lovely team, who I'm incredibly proud of. I won't go into sort of the background for everybody because I'm sure you guys don't have time for that. But interestingly, since we last visited, we now have a trainee clinical psychologist with us, which is incredibly exciting. So she is the student of our clinical psychologist, but she can now provide on-the-ground therapy for parents. So where we've applied and we know that there are huge waiting lists, there are difficulties with parents that have difficulties with drugs and alcohol, where there's a lot of barriers for those parents, and actually having that support now within FDAC, we're able to make that safe decision for those parents to engage in that therapy and being able to provide it very quickly. And because we're all talking in formulation, we're able to really understand what the needs of that parent are and not providing a sort of stamped, structured approach. We're able to look at what is it that parent really needs and provide that one-to-one, and then we review that every intervention plan. So that's really exciting. And our IDFA, our domestic violence advocate from the police, is due to join us in January. So she'll be part-time with us 3 days a week, and then she'll move into full-time in February, which is amazing. So our team's just growing and growing. So I've just put a list of the training that we've done in the last 6 months, which is quite a lot. The team have been incredibly busy. But importantly, the things for me are around the narrative exposure therapy. And I believe last time I talked a lot about the therapeutic parenting. We know in Northamptonshire we do managing behaviour with attachment in mind, and we talk a lot, and I know Olivia will come on to talk about the emotional needs of children being quite significant, and how do we address those by looking at emotions. And I was quite keen to provide that for parents, but in a way that doesn't trigger or shame them for their child's experience, because the things that have happened are unintended consequences of their substance use. They've not set out to do those things. So how do we help those parents meet their children's needs whilst acknowledging those difficulties? And our clinical psychologist, fortunately, had already started and had a programme running, and that's now completed and has been delivered to the team. So that's amazing. And I've got some feedback from the parents that have done that work. And the team are now trained in NET, it's known as, but narrative exposure therapy, so we can do that work with parents later on in the process as well. So there's lots and lots of support kind of coming in. Yeah, that's just me. This is what I say to the team quite often. When we no longer believe that people can't change, we have to ask ourselves why we come into work. We are very much a problem-solving team, and the difficulties that may have come up for families, we sit down with them and we say, right, this is a problem. Okay, how do we navigate that? And we're also doing that with professionals and services. So when we kind of sit down and we go, right, this is a difficulty, we're coming with that same approach everywhere, and it's been really well received. And the community support has been fantastic and continues to be. So, I have bullet pointed a list of our achievements. I don't know if you wanted me to go into all of those. So the timeline. So, we launched in April, and we had our launch event, I think it was in May. We already had a family signed up by that point, so we were already on it. And by the time we come here, we were sort of in the progress, weren't we, of working. But we have, at this point, just made our first recommendation for a unification for a family, which is really exciting, and hopefully one of many that we will see. But been really well received, and excellent work with the local authority, the judges, the guardians have been amazing. So really good work going on all round. So I do apologise that they're all kind of squished in, all in the one slide. But at present, we're on track to complete our 10 families in the first year. Those parents that we've assessed and have not felt that FDAC was suitable for those, we've been able to provide an intervention plan. So we're not just assessing and stepping away. What we're doing is saying to the family court and the local authority, these are the kind of services that we think these families would benefit from. We're signposting them to the bridge, S2S, and we're actually naming specific groups that we think would be helpful for them, so that those families aren't sort of feeling that they've had an assessment and nothing's progressed. So we're laying out those plans for those families, and that's really important, because for some of those families, they've not been in the right place in their journey with their substance use, and they've been able to kind of recognise that through assessment, which has been incredibly powerful for a parent to be able to do that and be able to provide that to the court. So it's been really positive, and we're currently in assessment with 2 families. a family with 2 parents at the moment as well, so we're still kind of going. I think importantly for me, we are still tracking a lot of the data, so we're not at the point yet where we can look at completed care proceedings and kind of compare that comparatively to lots of other data, but we are continually gathering. So one of the main things we've been focusing on is our GAD and PHQs, so that's our general anxiety disorder and more words have gone, patient health questionnaires. So we do those with parents at the very beginning of the process, and we do that at every review. And it's been amazing to hear parents kind of, they'll answer the questions, and then when they kind of look back at the scores, they're like, oh my gosh, I didn't realise actually I got much better at that. And being able to reflect on what they felt they weren't able to do at the beginning, like getting the bus and going to a group was a huge thing. And now they're kind of just doing that naturally and all the time. So yeah, that's been really good for us, kind of seeing that for parents. On to the next one, I think, the feedback. Yeah, this for me has probably been the most rewarding part of the work. So we've had the therapeutic parenting programme that the parent said that was helping her heal herself. One of the tasks we ask parents to do is really reflect on their own experiences of being parented, because we know that that is our blueprint for parenting, and not holding any shame about that. And these parents have been able to kind of do that in a really warm and empathetic way, and then they've been able to do that for their children. And watching them do that in a session is just the most powerful thing. But yeah, they're saying that they're finding it really healing at the same time, which is great. One of an older daughter, so an adult child, had come to us after a meeting and said, I finally have my mum back. And this is the mum that I remember when I was younger who used to read to me, which was really lovely. We've recently been engaged with a family who have struggled to see professionals in the last 6 months. And just by knocking on the door and just kind of doing that occasional, and just the chatter that we kind of have at the door, we were able to get into the apartment twice, and now they're fully engaged in assessment, coming to court hearings and all those things, which is brilliant. And when they left assessment, they said, the words were, thank you for listening to me today and treating me like a human being, which we know lots of services do those things, but for us, it's just part of that initial bit, kind of gathering that, and helping the relationship building between us and other services where that may have broken down. We've been able to do that as well, so it's been really, really lovely. I put a page on there for FDAC growth. This is probably more my wish list, and it's not prescriptive. But yeah, so we're looking obviously at business plan towards the end of the year, so when we are able to kind of pull all of that data together, because ideally we'd like to expand our social work, particularly in the team. But we're looking around the mental health. I'd like to strengthen that support in the team. Whilst we have a clinical psychologist, they are only there for like a limited time, and they've got set tasks to do. So kind of building that parents' accessibility to that within the team would be a dream of mine, and being able to run groups for our parents. So a lot of our parents that have kind of progressed through, they've actually made friends with one another. They've connected in other groups, which has been amazing. So yeah, we'd like to progress that. We know that beds FDAC have links with psychiatry, and I think that was one of the things that they looked at in terms of the delays it was causing to care proceedings. So having 1 day a month with a psychiatrist kind of enabled the quick assessments. But we're sort of gathering the information and the data that we need to be able to put those sort of things together and hopefully build those links. Yeah. And more links with community services. So recently I've just had a wonderful meeting with the sexual health outreach team for the North, and they're coming next month, February. So we'll be linked in with them as well, so that we can help deliver some of those services to the families that they may struggle to meet. And yeah, so we continue to do that. But yeah, that's my very fast update. I have I could talk about FDAC all day, but if there's any questions.
Thank you, Rachel. That was a whistle-stop tour, but I don't want it to undermine the work that I can clearly see that you've been going through since July. Open it up to the board for any questions for Rachel. David?
Thanks, Chair. Thanks, Brian. Thanks very much again. I suppose, I mean, it is a very joyful service for sure. So just to kind of make that plain, I said that in July, I'm still not entirely clear about what good looks like in the context of this. So what the total cohort of opportunity is for families who might benefit from the service. how much of a contribution this service makes. I know we've got 10, but what's the denominator, etc. That would really help, I think, because then it gives a sense of scale, opportunity, and indeed kind of galvanises me to think about the mental health support that you're describing as wanting to build in. That might be something I can help think about, but I'd need to understand kind of the wider numbers, if that makes sense, which I'm sure will be in the business case, but if it comes back again, we do probably need that, yeah.
Sorry, could you clarify what you mean in terms of the numbers?
So I guess, so you saw 10 families.
Yeah.
What was the number of potential families?
I'm on. Thank you. So we're collecting data for the referrals that have been sent to us. I believe there were 17 off the top of my head. I wouldn't want to give you the exact amount. But what we've done is screened those that we could have worked with had we have had capacity, as well as those that perhaps didn't meet the criteria. So that's being logged kind of as we go to build into the assessment, because we can only assess one family every 4 weeks. So if we get a number of referrals at once, we've not been able to do that. But that data is going to hopefully build into the business plan, business case.
And the goal is 30, isn't it?
And the goal is 30 for the next year. Yeah. Does that answer your question?
Yes, and the business plan will be helpful, I think.
Yeah.
Partners can then gauge where they can make contributions they want.
Yeah. No, we would really welcome that. Thank you.
Thank you. Any other questions from the board? No, well, thank you, Rachel, and on behalf of the board, thank you for all that you're doing, and it's very heartening to see the work growing, and particularly the comments that you put up on the screen there. They really amplify the value of the work that you and the team are doing. So this item's just for the board to note, so I'm sure that we can do that, and I'm sure that as you go through your journey, we'll invite you back again, and when you've got more data and more information to share with us. Okay, we're moving on to agenda item 13, which is the Northamptonshire Safeguarding Children's Partnership Annual Report 24-25. And just once again to remind everybody that I'm very grateful to Judy for standing in on this item. So Northamptonshire Council was one of 5 strategic leads representing the multi-agency Northamptonshire Safeguarding Children's Partnership, which is a statutory requirement of the Working Together to Safeguard Children 2018 guidance. The partnership is required to produce an annual report that provides an overview of the partnership's achievements against the NSCP business plan. So, Judy, it's over to you to fill us all in.
Thank you, Chair. This report seeks to advise everybody of the achievements to date this year, and also to set the priorities for next year. But just listening to some of the reports that we've heard today, I think there's a golden thread going through all of them, and I keep hearing the same things about the importance of child and family voice, and the language around right help, right time, and that early intervention, and that kind of is also threaded through this report. So during the last year, there has been an extensive review and rebrand of the Thresholds document, which was launched earlier in the year, and it was called Right Help, Right Time, Continuum, and on a continuum of need. And to embed and support that training across the partnership, a comprehensive training programme is in place, and people can access it. The NSCP website is also further progressing, and it's creative and simple to use, and it now includes a new learning management system which allows us to build our own local e-learning courses subject to the needs of the partnership. And within that website, there is a new video has been produced collaboratively, which outlines the work of the work of NSCP, and it's quite straightforward and easily easily digestible for everybody to understand exactly the work that we do. Also, the Child Exploitation Hub has been set up and is now running. It's a multi-agency hub, and it is set up to respond to support the needs of children and young people at risk of exploitation. And that multi-agency approach is very supportive and actually helps kind of cross-fertilise the knowledge across the different agencies. The report does include feedback from children, young people and families, and it ensures their voices have been reflected and heard, and also evidences the impact of some of those interventions. And the report has tried to be relayed in a way that is accessible and easy to read and is family friendly. Coming up for the next year, the priorities that have been outlined are alignment with the new social care reforms, and that kind of follows a family help strategy as well. And the NSPC are responsible for overseeing that Families First project in Northamptonshire. And the real focus, as with everybody, is around that robust family help support network, as opposed to just centred around one child. Those are kind of the items that they wanted me to draw to your attention, and I'll happily take any questions back that you might have, because I might not be able to answer them.
Thank you, Judy. Are there any questions for Judy, looking around the room? Oh, Judy, that looks like you got away quite lightly, but bravery deserves. So I just think that in terms of this particular report, the board is just asked to note the contents of the report. So is the board happy to do that and move on? So thank you very much. We move on to the last item on the agenda, which is our mental health in care leavers paper, and this report is to provide information to board members as to how young people experience mental health and emotional well-being as they may leave our care, and how they are supported following a discussion at the board meeting in September. So can I invite Olivia Ives to present this report? Over to you, Olivia.
Lovely, thank you. Thank you for having me today. So I will work on the basis that people have read the report, and I hope also were able to access the video that was embedded, which is of one of our care leavers sharing his experience of the services around mental health for care leavers. And I guess just to summarise some of the information within the report, what we see is it's a really complex picture. And the benefit of going last on the agenda today is that you can see the link between the mental health of our care leavers and many of the other things that we've talked about today. You know, the family help hubs, the SEND systems, they all link together, really. What we know is that so we introduced nearly 2 years ago now a new assessment model, value and care assessment tool, which is a needs-based assessment tool, which has kind of changed how we are thinking about young people and their needs rather than focusing on their behaviours. And consistently, the Circle to Success assessments, which they've become to known as, tell us that the emotional health and well-being of children and young people and managing emotions, which are two separate needs identified within the assessment tool, are the highest needs for our young people. And that's been for young people, not just our care leavers, but for all of our children in care cohort. We also know through the analysis of our Circle to Success assessments that there is a link between those young people with a severe level in terms of the emotional health. So the needs in the Circle to Success assessment are categorised as severe, moderate and low. So those with severe high level in terms of their emotional health are also more likely to have those severe needs in other areas. I don't think that probably comes as a surprise. but often those are unmet and or undiagnosed needs. Areas where we see that in particular around education. Often children are not in education. The ones with the most severe needs are those that are not in education, so maybe missing education or not in full-time education. Those that need support in understanding their identity. We heard reference earlier to LGBTQ, but also wider than that in terms of connections to family members and making sense of their experiences and their family relationships. There's also a correlation with our young people with additional needs, so those with special educational needs and disabilities, ASD, and mental health, which you will all be familiar with the link between those. So I think what I would say is one of our biggest challenges is how mental health is viewed in children. So our care leavers are children who are young people who have been in care and met the criteria to become care leavers. So many, not all, but many of our children in care will become care leavers. And I think one of our challenges is how mental health is viewed for those children earlier on, and the interlink with trauma. And that becomes much more apparent as children head towards adulthood and then hit 18, and then we have this cliff edge at 18 for those who have received support as children, where perhaps their mental health needs were identified as trauma-related or attachment-related needs, and then when they become adults, they get labelled as something different. Some will become those that have the diagnosis of emotionally unstable personality disorder. Sometimes that's identified early as emerging. Others, it means that at 18, they couldn't receive services as a child, but suddenly they're receiving something different as an adult. So we've got this kind of disjointed system, I would say, at the moment, which doesn't meet the needs of all of our young people. And I think that was probably articulated quite well by James in the video, which tells us we don't always get it right. So we know that some of the things that work really well for our young people is around a flexible offer. And that flexible offer is making sure that we've turned right help, right time. It's exactly the same principle for our young people with mental health needs. We have embedded within the Leaving Care Service a mental health practitioner who is funded by NCT and seconded from NHFT. And she makes a significant difference to a very small proportion of our care leavers. But part of the difference that she makes is because of her availability, flexibility, different ways of being able to engage with and link up with those young people. The other thing that we know we need is carers, whether they are carers in foster homes or whether they're supported accommodation, residential homes, who are resilient and understanding of children's mental health. And much of the support that we offer as a whole system is around supporting those carers to look after these children with complex needs, even when those young people are not ready to access that support directly. I've talked about that cliff edge at 18 and that point where there are many changes in young people's lives, and what we need to achieve, I think, as a whole system is a degree of consistency, and not for it to be you're on this pathway today and tomorrow you're on something different, or you meet the criteria today, tomorrow you don't, or you didn't then but you do now. So I think we need to challenge ourselves to think differently around that. In a leaving care service, we support young people up to the age of 25. We don't have a 16 to 25 service as such for mental health. I think thinking about that might assist some of our young people. The other thing we also know is that young people need an important person in their life. It doesn't matter really who that important person is. It could be their personal advisor in the leaving care service, it could be somebody in education, it could be a mental health practitioner, it could be a parent or a family member, but we need to support young people to identify who that is and ensure that that connection is available to them and maintained. And I think we, certainly through our care of our children and young people, can create barriers to those connections being in place. I think the other thing that would be really useful, and we are developing as a training programme for our accommodation providers and for our carers, so that, as I said earlier, they can understand and support the mental health of our young people. And then thinking about how do we join up all of our services. Sharon Sandell, who is the strategic manager for Leaving Care, wrote the report and talks about the importance of speech and language support. And I think we underestimate that actually for our young people. We are in the process of developing what we call our Circle to Success Hub, which is a specialist children's home based on the Yorkshire No Wrong Door model, which will have a speech and language therapist working within that home when we get there. We're just in the process of kind of developing the hub and making sure that we've got that right. So we may come back and be saying, how can partners support us with this new hub and the support services that we have within there. So I guess today my request is really that we just hear what our young people are telling us, importantly, and challenge ourselves to think about how we can create that much more joined up system for our young people, which starts right back down with our children as soon as they, well, I talk about children in care, it's actually the whole of our community of children, but thinking about how we meet their needs at an earlier age so that when they become care leavers, they are the resilient young people who have the tools, I guess, within and with some additional support to cope with the challenges that life throws at them.
Thank you, Olivia. And I think it's reading the report. There's some quite sobering statistics in there. I think particularly the one that struck me was in section 4.8, which shows a capacity level of 3%, where the need is 40% in some and 80% in another cohort of children. So it's quite sobering when you actually sort of step back and just read it in, on a cold report like that. But just before I open it up to questions, I just wanted to pop back onto the point that you made around Circle to Success Hub. I'd be very keen as you develop that, if you can keep us alive as a board and actually bring back some an offer of what you've developed. So I think if you're happy, I would like to put that as an action to come back to the board at some point.
Yeah.
No particular timeline, because you need to drive that work yourself, but I think I certainly would like to see that. So if you're happy, we'll take this as an action.
Thank you.
Okay, open up for any questions for Olivia on this topic. Yes, Trevor.
Yeah, two areas of question. One is relating to, and I don't know the sort of setup in North Hants, but it's about children that are in care, but not actually North Hants children, but they've been placed in North Hants by other organisations. And the extent of responsibility at the age of 18, that then, does it shift over, and do we have the support mechanisms there for those children, or as they then are, they're coming out of the system? The second one was concerning, there are a number of large organisations that provide a number of the supports in the homes, and it's how much the onus needs to be with them and ourselves in terms of providing that sort of, whether it's from 16 or 15, that transition to enable the young people to be able to come out at the other end, being able to manage some of those transitions, whether it's their mental health at that point in time, or actually maybe the mental health that arises post having to get a job, having to leave the security of that process they've been in for that long. So it's really sort of those two questions.
Okay, so in terms of the first question, young people who have been in care to other local authorities remain the responsibility of those local authorities as care leavers. However, in terms of, so that's in terms of a social care perspective, in terms of adult social care, in terms of health services, I believe it becomes the responsibility of...
Do you want me to answer?
Yeah, do that bit. Yeah.
So at the age of 18, it really depends on the circumstances of the young person. So there's a piece of legislation that's in relation to ordinary residents. So if the person has care and support needs that are eligible under the Care Act and have been placed in Northamptonshire and there's no break in that service, they would remain the responsibility of the placing authority. If the care and support can be provided in the person's own home and they have capacity to choose to make Northamptonshire their home, then it becomes the responsibility of Northamptonshire. There's some caveats to that. If you were detained under the Mental Health Act, that would break that status under 117, but broadly they're the principles.
Any other questions for Olivia?
Did you want me to come back on the second part?
Oh, sorry, yes, please. Yeah, sorry.
So I think that was about kind of how we join up our services. I think that's our biggest challenge, actually, is there is a wide offer for children and young people through kind of voluntary sector, our statutory services, health services. You know, there's a long list of resources available for them at a young age. I think how we join them up and ensure that everybody knows about them is one of our challenges. And your point was around kind of the transition and age 15 plus. And we are working really hard within local authority with adult social care through the SEND work around developing that preparation for adulthood work and thinking about those needs of those young people at the earliest age. In NCT, we have what we call our Transitions Outcomes Group, which is a panel that operates, multi-agency panel, that includes adult social care, education, various other organisations, to think about the needs of young people at the earliest point, which is not just about their education needs, but any of those needs, health needs as well. And thinking about what we need to be doing to support that young people in their preparation, that young person in their preparation for adulthood, and bringing those services together. So there are mechanisms for thinking about it at the earliest point. I think what our young people are telling us is that we still need to do more around that.
Thank you, Olivia, and apologies for cutting you off halfway through your answer. Any other questions? No? Looking around the table. Well, thank you very much, Olivia, for that. That brings us to the close of today's meeting. We've slightly overrun, so once again, my apologies. But I just would like to say it's our last meeting of this year. But a big thank you to everybody for particularly the support that you've given me as the chair, but also for your fantastic contributions. I think today's meeting has probably elicited the most questions and the most discussion on any board that I've chaired since being elected in May. So thank you all very much for that. Let's continue it in the new year. And can I just take this opportunity to wish you all a very Merry Christmas, a joyful and peaceful break, however you celebrate it. I will be off on my holidays at the end of the week, so I shall see you all in 2026. But thank you very much indeed.